My name is Andrew Coggins. I'm one of the staff specialists at Westmead Hospital here in Sydney. And I'm going to talk to you for about 20 minutes about the acute respiratory distress syndrome, which I think is a really interesting topic to cover. The condition can be relatively hard to recognise. It's essential to be able to distinguish between acute respiratory distress syndrome and other causes of infiltrates on a chest x-ray. Likewise, the condition has several potential management strategies, both in prevention and treatment, but many of these strategies are non-specific to the condition. So what are our learning objectives for the talk today? Number one, we have to be able to define acute respiratory distress syndrome under the new Berlin criteria from 2012. Secondly, we need to know the common causes of acute respiratory distress syndrome in order to recognise it when it is present. Thirdly, we must describe the clinical course of the disease. We must be able to recognise it and list some differential diagnoses for ARDS. Finally, we must be able to discuss the prevention and management of the condition. Let's start off by discussing the definition, the causes, and briefly touching on the pathogenesis of the condition. The definition of ARDS has been updated in 2012 at the Berlin Consensus Conference. This has led to the removal of acute lung injury as a internationally recognised diagnosis, and ARDS is now stratified into mild, moderate, and severe forms of the disease. We'll touch on the causes of ARDS, which can be both direct and indirect, as well as the pathogenesis. So we'll start off by going through a case example. A 42-year-old male presents to the emergency department with progressive shortness of breath with myalgia. He has a fever and has been tachycardic at triage. Initial blood pressure was 90/60, and he is treated with broad-spectrum antibiotics, given some fluids, and admitted under the respiratory team. On day 2 of the admission, the patient deteriorates. He becomes more short of breath. He has a chest x-ray which shows progressive lung infiltrates with a normal heart size. He has an arterial blood gas which shows a PaO2 of 50 millimeters of mercury, and at this point he's on 50% oxygen via a Hudson mask. The team looking after the patient are very concerned about the high alveolar arterial gradient present on the blood gas, as well as the increasing changes on the chest x-ray. We'll come back to this case later in the talk. Needless to say, the team are suspicious this patient may have acute respiratory distress syndrome. So what is acute respiratory distress syndrome? Well, ARDS was originally described, as we said, in the 1960s, and there was evolution of the definitions in the 1990s. In the early 2010s, there were significant updates in the criteria for ARDS. The Berlin criteria redefined what it meant to have acute respiratory distress syndrome. So what are the typical features of ARDS? Well, it's usually acute in onset. There are often very significant bilateral chest x-ray changes which affect at least 3 segments of the lung. There's no evidence of any heart failure or left atrial hypertension, but there may be coexisting changes in pulmonary artery pressures and capillary wedge pressures. This has therefore been removed from the definition of ARDS in the most recent iterations of consensus guidelines. There may be varying degrees of relative hypoxemia in these patients, varying from mild to very severe, and this seems to correlate fairly well with mortality of the disease. ARDS should be understood as a condition which has many causes and has a high mortality. As we mentioned, the original definition of ARDS was described in the 1960s, where Asbaugh and colleagues described in The Lancet in 1967 acute respiratory distress in adults. In the 1990s, a consensus conference recommended a simplified criteria. The criteria included significant arterial hypoxemia with a significant decrease in the ratio of PaO2 to FiO2, and they defined both acute lung injury and ARDS respectively on the severity of this hypoxia. They also said that the patient needed to have bilateral radiographic opacities without evidence of any left atrial hypertension, and that could be defined in a number of ways. The present-day criteria has been updated and simplified into mild, moderate, and severe. With a standard amount of PEEP, we define mild, moderate, and severe ARDS with the removal of acute lung injury. The mortality goes up depending on the severity of the relative hypoxia, as you can see in this slide. So what are some of the caveats we must consider when making a diagnosis of ARDS? Well, the first one is that it's a clinical diagnosis. It relies on our clinical judgment and our gestalt to actually make the diagnosis, which can be variable. Many patients with a defined diagnosis of ARDS may be improving and may in fact resolve quite quickly. Other patients may have other causes of the abnormal chest x-ray or the condition that they have at that time. The condition is very uncommon outside of the ICU setting, and there are multiple potential associations and causes, and it's unclear whether these are associations or in fact whether they're directly causal of the injury, and it's very hard to tell that at the time. One interesting thing to note is that if you take patients with ARDS and they have an autopsy, only about half those patients will actually have definitive evidence of ARDS histopathologically. With these caveats in mind, it's difficult to conduct quality randomized controlled trials where the condition you're looking into is hard to define and hard to diagnose. The condition itself does have a very high mortality when present. We'd like to move on now to talking about the causes of ARDS. In general, these can be divided into direct and indirect causes. Direct causes are direct injury to the lung itself. The lung parenchyma is injured by things like pneumonia, aspiration events, drowning, inhalational injuries, embolic phenomena such as amniotic and fat embolism. The indirect causes are very vast, but the typical ones that are described in the literature include severe septic shock, massive transfusion, and pancreatitis. But really, there's a whole host of potential causes of indirect injury that are associated with acute respiratory distress syndrome. So what's the prognosis for ARDS patients? Well, according to one study, the likelihood of survival is determined by the severity of lung injury, the extent of the non-pulmonary organ dysfunction, and the pre-existing medical conditions and the quality of the supportive care. So in other words, it's a multifactorial and hard to predict. But the one thing we can say is that the range of mortality when this condition is present is very high, in the range of 20 to 50%. Patients with direct lung injury appear to be at greater risk of death, and particular patients such as alcoholics seem to be at higher risk as well. The trend in mortality in recent years appears to be going down to some degree. Various studies have reported lower overall rates of mortality in this condition. The graph here shows some major trials looking at the condition over the last 20 years and how there's been a reduction in the relative mortality of the patients. This could be due to a number of factors, but one thing to say would be gradual improvements in the overall critical care management of these patients is likely to be a factor, as well as improved ventilation strategies. The pathogenesis of the condition is very complicated and beyond the scope of this talk. One thing we can say though is that there's a basic process of an injury to the lung followed by changes in the vessel caliber, a release of various cytokines, and as a result, injury to the lung and lots of fluid there. This impairs the compliance of the lung and makes a change in the dead space, which prevents adequate ventilation. This leads to progressive hypoxia and hypercarbia, depending on the patient's underlying respiratory condition. The pathogenesis is defined on the left-hand side of the screen. So there's dysregulated inflammation, an inappropriate accumulation and activity of leukocytes and platelets with uncontrolled activation of the coagulation cascades. There's altered permeability of the alveolar, endothelial, and epithelial barriers. So this seems to be the central pathophysiological concept in the condition. A summary of the pathogenesis is shown here, with the end outcome being hypoxia. There's a number of different factors that contribute. So we'll take a question now. So a question for you. So you need to answer this multiple choice question. So which of the following is the least recognized cause of acute respiratory distress syndrome? Is it direct lung injury, indirect lung injury, pneumonia, or cerebral edema? So I'll leave you to think about that one for a sec, and then we'll give you the answer. So while there's lots of causes, as we discussed, both direct and indirect, it seems that cerebral edema would be the least likely of these to cause ARDS. So we're going to move on now to discuss briefly about the differential diagnosis of the condition. So the differential diagnosis is extremely long because there's a lot of causes of things that can cause bilateral infiltrates on a chest x-ray and hypoxia. The main one we're worried about in this case would be congestive heart failure. So the main differential, as we said, is congestive heart failure and pulmonary edema. The important thing to note here is that ARDS may overlap significantly with this condition, and this is why they've removed things like pulmonary capillary wedge pressures from the criteria. So it's interesting to note that even the experts cannot agree exactly what a chest radiograph should look like in ARDS. We've got two examples of chest radiographs here. On the left-hand side, you have a typical appearance of the patient with congestive heart failure, a large heart size, the bat's wing appearance, some septal lines, small bilateral pleural effusions. On the right-hand side, this is an appearance of an ARDS patient with bilateral diffuse infiltrates. The patient's obviously very sick with a tracheostomy tube present, as well as significant bilateral changes. The heart size is relatively large, but on the other hand, the patient is having an AP projection for the x-ray, so that may make the heart and mediastinum look slightly more wide than what you might otherwise expect. Some of the differentials to consider would be a left ventricular failure. Clearly this would be the typical appearance of the x-ray on the left-hand side with rapid onset of shortness of breath. This may respond relatively well to appropriate measures to reduce the preload, such as continuous positive pressure, ventilation, as well as giving the patient appropriate medications to diuresis. In the emergency department, we often use GTN for these patients as well if the blood pressure will allow. Lymphangitis carcinomatosis is a typical infiltrate which is seen in patients with diffuse malignancy, typically lung and breast malignancy, and these patients will often have old chest x-rays which show the infiltrate as well. Pulmonary hemorrhage is always worth bearing in mind in patients who are anticoagulated, especially if there's a sudden drop in the hemoglobin associated with a background of things like bronchiectasis. And this doesn't typically cause bilateral hemorrhage, but it can do. So it's something to bear in mind when you have a patient with a diffuse infiltrate on the x-ray. Underlying fibrosis can certainly cause this picture. So if the patient has a history of rheumatoid arthritis or other inflammatory conditions which could be associated with a interstitial lung disease, always consider this as the possible cause. So typically patients who have ventricular failure may have things like evidence of fluid overload elsewhere, such as a raised JVP, a peripheral edema, and the patient may have an underlying heart disease, so you should look at whether there's any murmurs or not. So what would your differentials be in this patient? Well, clearly we've just discussed this. I'm just wondering what you guys think the differentials would be for a patient who's been in the hospital for a couple of days with progressive infiltrate on their x-ray and shortness of breath. Why don't you write down 3 differentials that you would consider? So here is our patient's x-ray. On the left-hand side, you can see the initial x-ray in the ED suggesting a possible chest infection, possibly some basal collapse consolidation. And on the right-hand side, we can see that the patient has an endotracheal tube marked with the arrow, lots of ECG monitoring, and a bilateral infiltrate, which is concerning for a picture of a acute respiratory distress syndrome. So we're taking another question now. So question 2, which of the following features on a chest x-ray would not suggest ARDS as the cause of hypoxic respiratory failure? So your possible answers are diffuse bilateral alveolar infiltrate, absence of a pleural effusion, atelectasis and nodules, a large heart, and finally atelectasis in dependent lobes. So the correct answer in this case is the large heart size, although it's not specific, it may be suggestive of a patient with pulmonary edema. So the final section of this lecture is about the treatment of acute respiratory distress syndrome. Many of you listening to this lecture may be more experts than me, given my background as an emergency physician. Generally, our job in the ED is to try to prevent ventilator-associated complications by using an appropriate ventilation strategy. Up in the intensive care unit, however, there's more specific and supportive treatments that you can provide. But the one thing we can say is because ARDS is a complex syndrome with a broad clinical phenotype, it's quite challenging to translate results of cell and animal studies looking at the condition into actual pharmacological therapies. Dr. Rob McSweeney, an intensivist from Belfast in the UK, has a specific approach to the treatment of patients with acute respiratory distress syndrome, which includes ventilation strategies, adjuncts to ventilation such as paralysis, restrictive fluid strategies, drugs which don't seem to be particularly effective in randomized controlled trials, and finally, in refractory cases, the use of extracorporeal membrane oxygenation. So what therapies have been shown to reduce mortality in this condition? Well, the two main ones would be the lung protective ventilation strategy, which both prevents and treats it, but it's not specific for this condition necessarily, and it may be that patients benefit from various ventilation strategies due to this general application across all critical care patients. The other thing that seems to prevent this is a limited fluid resuscitation, in other words, to restrict the amount of fluid that the patient gets in the intensive care unit and prior to arriving there as well. So a couple of the papers that are relevant in this are the ARDS studies. So both in 2000 and 2006, there were studies looking at fluid restriction as well as tidal volumes. And the first paper in 2000, basically from the ARDSNet group, looked at comparing a low tidal volume versus a high tidal volume and showed significant improvements in mortality from the low tidal volume strategy. So this is how we manage the patients in the ED to prevent acute respiratory distress syndrome, and a standard way to ventilate patients in the intensive care unit. The comparison of two fluid management strategies in acute lung injury, this was a paper that came out in 2006. It's also been referred to as the FACT study, F-A-C-T-T. There was 1,000 patients in this study with acute lung injury and ARDS, and they compared a restrictive fluid strategy versus a 7-litre positive fluid balance at day 7. And the 60-day mortality in these patients showed a significant improvement. In the last couple of years, there's been more interest in various different ventilation and strategies as well as inhaled vasodilators like nitric oxide. Nitric oxide seems to be reasonably useful in very severe refractory cases in terms of improving oxygenation, but there hasn't really been demonstrated improvements in mortality using this therapy. So it seems to be reserved for special cases, and it's obviously an inhaled therapy which you might want to consider using in these patients with expert supervision. Ventilation strategies that may improve oxygenation include lying the patient prone and also using oscillatory ventilation. The latter has been disappointed, but prone ventilation seems to be a significant benefit in the 2013 study. The Perceiva study came out in 2013 and basically showed quite impressive results with patients that were in the prone position. This has a number of different physiological effects on ventilation, but essentially can improve VQ mismatching and may improve mortality. So there's going to be more papers coming out on this. Logistically, obviously, ventilating a patient in this position is quite challenging, so we need a team approach to achieve the results they got in the Perceiva study in your intensive care unit. So we're coming towards the end of the talk now, so we're just going to quickly go through some other proposed therapies for ARDS. Some of these have been quite disappointing. So Ketoconazole and salbutamol have had randomized controlled trials. 10, 15 years ago, these were often used as they had some theoretical benefit in the patients with ARDS. But disappointingly, ketoconazole and salbutamol have both been shown not to really improve mortality in these patients. We've already touched on inhaled vasodilators, but things like nitric oxide can be used to improve oxygenation, but haven't been demonstrated to improve mortality significantly. There's lots of anti-inflammatories that have been trialled, and currently there's interest in using statins, but things like Nurofen and other anti-inflammatories, non-steroidals, as well as steroids have been trialled. There have been some studies that have shown steroids to be beneficial, but there's mixed opinions as to whether this is really beneficial to all comers to the ICU with the condition. Finally, extracorporeal membrane oxygenation, or ECMO, may have an increasing role in the future for these patients with refractory respiratory failure. There are some other therapies to consider. So paralysis and nutritional therapy have been on the list of many people for the treatment of ARDS for some time. So the benefit from paralysis was shown in the Accuracy study. Again, another study coming out recently showing a significant benefit from neuromuscular blockade with cisatracurium versus placebo. There's also some possible benefits from sedating patients and also from nutritional strategies which may reduce the oxygen consumption and demands associated with the critically unwell patient. These treatments, however, are very non-specific for ARDS. Other things you can do, practically speaking, is you can reduce the amount of dead space by getting rid of things like excess tubing and changing the humidification of your circuit to reduce this dead space, and this may improve your CO2 to some degree. Other things, as we mentioned before, things like ketoconazole and beta agonists have been very equivocal or certainly disappointing when tested in randomized controlled trials. So for your interest in these general ICU therapies, here's some specific papers courtesy of Dr. Alex Yartsev from derangedphysiology.com. So it's been a bit of a long journey over the last 20 minutes or so. I've got one last question for you. Question 3 is, which of the following has an evidence base from randomized controlled trials in reducing mortality in ARDS? Is the answer A, ketoconazole, B, limited tidal volumes and lung protective ventilation, C, prone ventilation, or D, increasing the PEEP? So given the recent studies showing improvements in mortality with prone ventilation, that could be the correct answer. But I think in this case, the established evidence is around, from Cochrane review and from very large RCTs, that limited tidal volume both prevents acute respiratory distress syndrome, but also reduces mortality in patients with the established condition. So I think this is the best answer in this case. So we really appreciate you taking the time to listen to this lecture over the last 20 to 25 minutes or so. The take-home points about acute respiratory distress syndrome are really just practical things. You need to consider this condition in the unwell hypoxic patient, either in the ED or in the intensive care unit. It's usually of an acute onset, and it needs to be differentiated between itself and other conditions such as congestive heart failure. When diagnosed, it does have a very high mortality. The chest X-ray is going to show diffuse bilateral infiltrates, and you have to know something about the Berlin criteria, which defines the disease from 2012 and beyond. And there's no real such thing as acute lung injury anymore. It's all ARDS, mild, moderate, and severe. There's many causes and many associations, and many of the treatments are very non-specific. The treatment itself should be focused on the prevention and ventilation strategies, and obviously treating the underlying cause, everything from pancreatitis to trauma, burns, through to sepsis. And really, at the end of the day, the good critical care principles are what are paramount in the treatment of this condition. And the future direction may involve using more ECMO in refractory cases. So in regards to thanks for this talk, thank you to Dr. Alex Yartsev and Dr. Rob McSweeney, two intensivists who I've used many of their excellent resources to prepare this talk for you today. So thank you very much for listening to the talk. Many of the resources available in this talk are available on our free open access website, which is emergencypedia.com, where we've got notes for emergency department and critical care issues. So if you like this talk, please go there and look at the resources there.